Hi, welcome back to the Science of COVID-19. In this video, I'm going to talk about how epidemiologists model the spread of the virus. So I should preface this by saying that there are many different kinds of models for looking at disease spread. This is one of the common models used called the SIR model for infectious disease. And that stands for susceptible, infectious, and recovered. And so in this model, think of everybody that you're trying to model, whether in a community, in a country, in the whole world, as fitting into one of these three categories. Either they're susceptible, meaning that they've not encountered the virus and they could get infected. They're infectious, which means not only are they infected, but they're at a stage where they could pass this on to somebody else. And recovered, meaning that they've recovered for the infection and they cannot pass it on now to anybody else. Now, susceptible individuals move to the infectious class at some rate, let's just call it beta, and infectious individuals move to the recovered class at another rate, let's just call it gamma. Interestingly, you could also model a case where people recover, but then in the future, they could get sick again. So this is something that would be relevant to, for example, the flu, where just because you get it 1 year doesn't mean that you're immune to the flu for the rest of your life. With coronavirus, we're not sure how long the immunity lasts if you get it. This is partly because it hasn't been in the human population for that long. So we don't know if people who got it last year could get it again this year or the next. However, for a lot of the models that are in place or that have been created, we're going to assume that once you recover, you've recovered. And this makes the mathematics sometimes more tractable. However, it's important to realize that in reality, it might be that you can go back from recovered to susceptible, and there have been models that have simulated that situation as well. Okay, so in a general sense, this is what the model would look like if you were to graph everybody going from one class to another over time. So at the bottom here is time in days, and on the y-axis here is proportion of the population. So 0.4 would mean, for example, 40% of the population, 1 would be 100% of the population, and so forth. So we assume that on day 0, the entire population is susceptible. And this would be the case if you're modeling the spread of this disease in a population that hasn't seen it before. So the invasion of a virus, for example, into a new community. Even on the worldwide scale, initially, this is a very useful assumption because coronavirus came from an animal host. So initially, nobody in the human population had seen it before. So everybody's susceptible at the beginning. Now, over time, in red here, people start getting infected. And as people start getting infected, the number of people who could get infected goes down because some of them have already gotten infected, and the number of people who have recovered goes up. So that by the end, in an ideal model, you have everybody recovered, nobody infected, and nobody who could get infected. Now, in reality, you're not going to have no susceptible people at the end. It's not going to be 0%. And that's because of something called herd immunity, which we'll get to in the next video. And likewise, then not everybody would have been recovered because not everybody would have gotten sick. But to a first approximation, this is roughly accurate. So how does this model work? Well, everybody is susceptible at the beginning, and people start moving into the infectious class as they become exposed to the virus. And beta here is called the transmission rate. It determines how fast people move from the susceptible class to the infectious class. And it depends on two things. It depends on the contact rate, meaning how many people you run into every day, let's say, and the probability of getting infected per contact. So how many of those people do you run into are themselves infected, and how likely is it that you're going to get infected per person that you run into? So, for example, if you run into 100 people a day and they also interact with 100 people a day and they're not wearing masks nor social distancing, it's probably likely that you're going to move to this from susceptible to infectious at a higher rate, or in less time than it would take for somebody, let's say, that's only interacting with close family members, wearing masks, social distancing, and so forth. So people start generally or gradually moving into the infectious class over time. And after some time, the first person who moved in goes into the recovered class, and so forth. Now, this gamma term, meaning how, the rate at which you go from infectious to recovered, is defined as 1 over the number of days that the infection lasts. For COVID-19, in on average, you're sick for about 14 days. So, or you're infected, I should say, for 14 days. You might still feel sick for longer, but the virus is detectable and you could possibly be transmitted in, let's say, for about 14 days, meaning the virus levels are high enough that you could pass it on to somebody else. So then gamma would be 1 over 14. And at the end of the simulation, most people are in the recovered class, and then some people, very few, are left in the susceptible class. So these simulations are done by computer programs these days, and this is just an example of what it would look like. So on the left column are the days, and then you have the number of people that are in the susceptible class, infected class, and recovered class. So let's say on day 1, you have 20,000 people that are susceptible, 5 are infected, none have recovered. On day 2, about 19,980 people are susceptible, 19 have recovered, 19 are infected, and about 5 have recovered. And on day 3, fewer people are susceptible, about 78 people are infected, and 24 have recovered. And you go through this day by day by day until your susceptible numbers go down to 0, your recovered goes to the number that you started with, and there are no more infected individuals. And I should mention that I got this data from a website called kx.com, where they show dynamic modeling of COVID-19. Take a look at it if you would like, and you can see some simulations about this. Okay, now the susceptible infectious recovered model, unfortunately, is not adequate for COVID-19 because, of course, we need to include a death category. A lot of people who are infected and infectious do not recover and they die. And so then there is a rate mu at which people die or enter the death category. Now, you can make this model as complicated as you want. So that shows sort of the basic framework. In this publication, the authors made a more complex model where they showed individuals in the susceptible category, in the exposed category. So this means that they've been exposed to the virus, but are not yet themselves infectious. Then they can move to either an infectious mild category where they don't need to go to the hospital and they can recover, or an infectious case category where they're sick enough to need to go to the hospital. And even within the hospital, they can go to a regular hospital bed or an ICU bed. From either place, they can either die or recover. With the ICU bed, there's a path to go to a step-down bed and then to the recovery category. And so you might be wondering, why go through and model all of these very detailed steps? And the reason is that one concern that a lot of policymakers and healthcare professionals and scientists have is overwhelming capacity of the healthcare system. So you may have heard about this phrase called flattening the curve. And what does this mean? Well, let's take a look here. So this is days after the initial outbreak on the x-axis and the number of cases on the y-axis. So here is the number of people that are getting sick per day. And you can see that this dotted line is the capacity of the healthcare system. So think about that as, let's say, how many hospital beds are available for sick individuals who need to be hospitalized. So if you're here, you're fine. You can go to the hospital. You might not survive, but certainly physicians and doctors and nurses and other healthcare professionals will try their best and give you the care that you need. However, if you are over here, meaning you're above that capacity, you're in trouble because there are no more hospital beds available. So these people here, even if they're very sick, there's no way that they can get into an ICU bed, they can become ventilated, they can't get the care that they need. And so there's a much higher risk of these people dying without medical care. And what I've talked about so far is just additional cases of COVID-19. What about the person who has a heart attack or a stroke and needs to go emergently to the hospital? What about a teenager who's in a car accident and needs a blood transfusion? What about a child with cancer that has a life-threatening infection and needs to be hospitalized? All of those individuals are also in a very precarious situation because there are no hospital beds. So really the main reason for all of these policies that have been recommended and put into place about masking, social distancing, and so forth is to prevent everybody from getting sick at once. What you want to do is flatten the curve so that it's not so that at the end of the day, fewer people can get infected, which hopefully would also happen, but they don't all get infected at once. It's spread out over time so that you have enough hospital beds available should these individuals need to go to the hospital. And unfortunately, in the United States, there are already situations with needing to ration hospital care because the number of cases is above the number of hospital beds. So this was an article a couple of weeks ago from the Salt Lake Tribune, where it says that Utah's hospitals prepare to ration care as a record number of coronavirus patients flood their ICUs. And unfortunately, under these criteria, people who are getting worse despite receiving intensive care would be moved out first. In the event that two patients have equal conditions, the young get priority over the old, since older patients are more likely to die. So you can see that without enough hospital beds, doctors, nurses, other healthcare workers have to make some very, very hard decisions about who gets hospital care and who doesn't. So how can we decrease the number of individuals that have to go to the hospital at once? Well, really what we want to do is decrease beta. We want to decrease the rate at which susceptible individuals are becoming infected. And what are ways to decrease beta? Well, we have two options. We can either decrease the contact rate, so the rate at which people are running into each other and being together, or decrease the probability of getting infected per person that you run into. So what are the ways to decrease it? Well, social distancing decreases the contact rate. Lockdowns decrease the contact rate. Masks and face shields and hand sanitization decreases the probability that you're going to get infected per person that you meet. So these public policy recommendations are directly designed to decrease beta, decrease the rate at which susceptible people move into the infectious category to prevent too many people from getting infected at once. All right, the other really important piece that comes out of this is the R naught, which is how many secondary infections result from a primary infection. So what this means is how many people do I infect once I have it before I recover? Okay, and so this is sort of a population average. How many people do infected people on average infect before they recover? And using these parameters of the model, in this simple model, it's actually calculated as beta over gamma plus mu. In more complicated models, the equation to calculate it will be more involved. So why is R naught important? Well, it tells you what the epidemic will be doing. So if R naught is greater than 1, the epidemic is going to spread. If I infect, on average, more than one other person before I recover, and then they infect on average more than one other person, there is no way for the epidemic not to spread. So let's say this is me, I infect 2 people, they each infect 2 people, then they infect 2 people, and so the epidemic just grows. If R naught equals 1, that means that I infect one other person before I recover, and then they infect one other person down the line before they recover, and so forth, then the epidemic will be stable. It's not going to increase and it's not going to decrease. The only way for the epidemic to die out is if R naught is less than 1, which means that if on average I infect I infect less than one person, fewer than one person, before I myself recover. And so then you can see in this scenario, okay, it eventually dies down. Now, this is, of course, hard to do. There are some countries in the world where they've been able to achieve this, and that's because they had sort of a concerted national effort. Um, Everybody sort of bought into this idea of wearing masks, social distancing, quarantining. They had sort of a system where they would test everybody, regardless of whether they had symptoms, so that they could find people that were asymptomatic yet infected and quarantine them so that they couldn't spread it to anybody else. So it obviously it takes a lot of effort. Uh, Unfortunately, if we're as a country not sort of at this stage where we're going to be testing everybody and everybody is sort of buying into the mask mandate and things like that, then it's going to be much harder to control. So this is a really interesting study that came out in May of this year. And this was around the time that most states had economic lockdown. So they were closed, businesses were closed, and they were trying to contain and control the coronavirus. Now, this calculation shows the R naught, okay, over the entire state, average per county, okay? So, or I should say this, county level R naught, and then averaged to get you the R naught of the state for all of these states that are shown here. I think in this study, they calculated it for each state, and only these states are shown in this figure. So what did they do? They calculated the R naught for each county and then got a number that would sort of represent the R naught for that entire state. And what you can see is here, the red dotted line is an R naught of 1. So if the R naught for that state is on 1, it means that the epidemic is neither growing nor shrinking. If it is above 1, it means that the epidemic is growing in size. And if it's less than 1, it means that the epidemic is shrinking in size in that state. And what you can see, and so then in these blue bar lines around each of these small circles are the error bars. So, or your confidence intervals. No, let's see, they are the 25th and 75th percentiles. So, this is sort of the range within which the R naught lies. Now, what's interesting is that these are the R naughts of these states at the time when they are proposing to reopen their economies. And what you can see is that some of these states are pretty low. Often these states have lower populations, so it's easier to contain the virus. But a lot of these states, the R naught is just around 1 or even above 1, such as in Ohio and South Carolina, and here in Indiana. So what does this mean? This means that if they're barely containing the virus, their virus is still slowly growing, or not the virus rather, but the number of cases is still slowly increasing, then once they release these economic lockdown measures and open up restaurants, bars, beaches, gyms, and so forth, then you can imagine that without any other measures in place to contain the virus, the number of cases is just going to grow because the R naught is right at this threshold. And unfortunately, in fact, that's exactly what happened. So these are data from July 26th in the Wall Street Journal, actually from Johns Hopkins, but it was published in the Wall Street Journal. And what you can see is that the number of cases in these states have really shot up after the lockdowns were lifted. And in retrospect, it's not surprising. So for example, in Florida, the R naught was just above 1. Okay. In Mississippi, it was right at 1. In Tennessee, it was above 1. So it's not surprising that once these states released or they decreased their lockdown measures, the number of cases expanded because the epidemic was already growing slowly. And now you're releasing these measures that are keeping people apart. So now they're, interacting with each other on a close basis again, and the number of cases spiked. So the question is really, do we need other lockdowns? Obviously, as I showed you earlier data, the cases are increasing again. And there are concerns already, it's happening in some states, that there are not going to be enough hospital beds for individuals that need care. And some epidemiologists have actually suggested that we need to do periodic lockdowns. So in this model, for example, here is a lockdown where your cases are very low. You release the lockdown, or you relax those restrictive measures, and unsurprisingly, the number of cases shoots up. This is total cases. These are critical care cases that lag by a little bit. And then once they reach some threshold, then you lock down again. So the cases go down. Once they're at some lower threshold, you can release the restrictions again. The cases go up, you put the lockdown again, and they go down. And so these purple bars here are the length of each lockdown. Now, the good news is over time, the amount of time for which you have to lock down becomes less and less. But I mean, this is a long haul. We're all the way in 2022 by this point. And this is to prevent, again, us from surpassing the hospital capacity. I think that really the best long-term solution here is going to be a vaccine. Now, a vaccine will, of course, prevent individuals from becoming sick, and so it'll decrease the number of cases. Unfortunately, it takes time to develop a vaccine. I know that there are many efforts there by many different groups to develop vaccines out there. Just for context, vaccines for other viruses or diseases take between 10 and 20 years on average to be made. And that's because there needs to be a lot of testing done to make sure that the vaccine is safe and is not actually going to cause our body to react worse than it would be if we actually had the disease, which can happen if the vaccine is not made properly. So this is why I think it's just extremely important to do multiple rounds of testing in many different populations before a vaccine is distributed for widespread use. Thank you so much, and I will see you next time to talk about herd immunity.